Welcome to Health Code Blueprint. Today, we're covering ICD-10-CM Chapter 9, Diseases of the Circulatory System, I00 I99. We'll navigate the hypertension assumed relationship, fundamentals for coding acute myocardial infarction, and aftermath coding considerations for cerebrovascular disease. Disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Chapter 9 really revolves around one big question. Does ICD-10-CM assume these conditions are related, or does the provider have to document the link? Once you understand that distinction, everything else in this chapter becomes much easier. When the alphabetic index uses the word with, ICD-10-CM presumes a causal relationship. Example: hypertension with heart involvement. Unless the provider says they're unrelated, you code them as related. If the index does not link the conditions, you need explicit documentation, terms like due to, associated with, or secondary to. Example: hypertension due to hyperthyroidism. This condition is not linked in the index. You need the provider to state the relationship. Now, let's break down the core hypertensive relationships and how ICD-10-CM expects us to code them. Heart disease refers to structural or functional abnormalities of the heart, often caused by long-term pressure overload from hypertension. When hypertension appears with heart disease, ICD-10-CM assumes they're related. Assign I11 and add I50 if heart failure is documented. Chronic kidney disease is the gradual loss of kidney function. Hypertension is both a cause and a result of CKD. When hypertension and CKD appear together, the relationship is assumed. Assign I12 plus the CKD stage from N18. Last, when hypertension, heart disease, and CKD are all documented, ICD-10-CM gives you a combination code, I13. You'll still add codes for the type of heart failure and CKD stage. Some heart conditions require additional codes, like heart failure or myocarditis, while others, such as cardiomegaly, are already included in I11. If the provider documents that the heart condition is not related to hypertension, code them separately. Some hypertensive scenarios require strict sequencing rules. For hypertensive cerebrovascular disease, the relationship is not assumed. You need documentation linking hypertension to the cerebrovascular condition. The sequencing: first, cerebrovascular disease, I60 I69, followed by hypertension ICD-10 code. For hypertensive retinopathy, use H35.0 with the appropriate hypertension diagnosis code. Sequencing depends on the reason for the encounter. Alright, let's walk through a few special hypertension scenarios that come up all the time in coding. First, secondary hypertension. This is hypertension caused by another underlying condition, so you'll always assign two codes, one for the cause, and one from I15 for the hypertension itself. The sequencing depends on the reason for the encounter. Next, hypertensive crisis. This includes urgency, emergency, or an unspecified crisis. You'll assign a code from I16, and then add the code for the underlying hypertensive disease. Again, sequencing follows the reason for the visit. Then we have resistant hypertension. That's when blood pressure stays above goal despite medication. For this one, you'll add I1A.0 as an additional code. The primary hypertension code still comes first. For controlled or uncontrolled hypertension, the terminology doesn't change the code selection. You simply assign the appropriate code from I10 I15 based on the type of hypertension. And finally, pulmonary hypertension, which is classified under I27. You'll also code any associated conditions, and sequencing will depend on the encounter unless you're dealing with an adverse drug effect. These scenarios come up often, so having these rules at your fingertips makes coding much smoother. Let's move into acute myocardial infarction, one of the most detail-heavy areas of Chapter 9. An acute myocardial infarction occurs when blood flow to part of the heart muscle is blocked, causing tissue damage. ICD-10-CM considers a myocardial infarction acute for 4 weeks, 28 days. This time frame is critical for the proper coding of this condition. An acute myocardial infarction occurs when blood flow to part of the heart muscle is blocked, causing tissue damage. ICD-10-CM considers a myocardial infarction acute for 4 weeks, 28 days. This time frame is critical for the proper coding of this condition. STEMI, I21.0-I21.3, represents a complete thickness heart muscle injury and is identified by ST segment elevation on the ECG. NSTEMI, I21.4, involves a partial thickness injury without street segment elevation. Coding rules dictate that, when an NSTEMI progresses into a STEMI, assign the STEMI code. If a STEMI later appears as an NSTEMI because of treatment, it is still coded as a STEMI. For myocardial infarctions that are 4 weeks old or less, continue to report diagnosis codes from I21. If the patient is receiving aftercare related to the MI, assign the appropriate aftercare code. For old or healed MIs that no longer require active treatment, use I25.2. A subsequent acute myocardial infarction is a new MI occurring within 4 weeks of the initial one. For this scenario, we code I22 for the subsequent myocardial infarction and I21 for the initial myocardial infarction. This rule applies only when both myocardial infarctions are classified as type 1 or unspecified. Type 2 MI, I21. A1, assigned when the infarction is caused by demand ischemia, meaning the heart's oxygen needs exceed supply due to another condition. Types 3 to 5 MI, I21. A9, used for less common acute myocardial infarction types. Be sure to follow all code first and code also instructions, especially for post-procedural events. MI with coronary microvascular dysfunction, I21. B, is reported when the myocardial infarction occurs with coronary microvascular dysfunction or non-obstructive coronary arteries, such as in coronary microvascular dysfunction cases. Now let's move into strokes and their aftermath. Sequence your codes in this order. Assign the I69 code first to capture the specific sequela of the prior cerebrovascular event. Then add codes for the actual deficits, such as neurologic impairments, as applicable. If the patient has no residual deficits, you do not assign an I69 code. When the provider doesn't document whether the affected side is dominant or non-dominant, ICD-10-CM gives us default rules. Right side defaults to dominant. Left side defaults to non-dominant. Ambidextrous patients default to dominant. There is no presumed relationship between a procedure and a cerebrovascular accident in ICD-10-CM. These codes can only be assigned when the provider clearly documents that the CVA was a direct result of the procedure. To code accurately, confirm the following details. Was the event an infarction or a hemorrhage? Did it occur during the procedure or after the procedure? What specific procedure was performed? To code Chapter 9 conditions with precision, keep these 3 core principles in mind. Anchor on the relationship. Always determine whether the connection between conditions is assumed by ICD-10-CM or must be explicitly documented by the provider. Prioritize combination codes. Before assigning separate codes, check whether a combination code, such as those for hypertensive heart and kidney disease, captures the full clinical picture. Master the sequencing rules. Correct sequencing is essential, especially for cerebrovascular disease, subsequent MIS, and any condition with code first or code also instructions. Thank you for watching Health Code Blueprint. I'll see you in the next video.